Now the next topic is the mucopyramid carcinoma. Now we are coming to the malignant salivary gland tumors. Right? Now it is the most common malignant salivary gland tumor. In case of benign, it was polymorphic adenoma. In case of malignancy, it is mucopyramid carcinoma. It is the second most frequent of all the salivary gland neoplasm in occurrence. The term was first coined by Stewart, Foote and Becker in the year 1945. It consists of 5% of all the salivary gland neoplasms. Now, the etiology which is implicated in mucopyramid carcinoma is the therapeutic radiation, the radiation which is used for treatment of diseases. Then we have lipoidal installation or any other presence of foreign material within the gland. Now, the origin is the cells of the salivary gland, excretory as well as intercalated ducts. Now, coming to the clinical features, mucopyramid carcinoma is mostly seen in the, or it is most common in 3rd to 5th decade of life. More in females than in males. Side parotid gland is the most common gland which is affected, and intraorally it is the palate. And it is the most common salivary gland neoplasm which is seen in children. Coming to the clinical presentation. First, we have the low-grade variant, which is slowly enlarging, painless mass, seldom exceeds 5 centimeters in diameter. It is not completely encapsulated, often contains cyst which is filled with viscoid as well as liquid material. Sometimes the people, or rather, the mucopyramid carcinomas mistaken as mucosal. Then we have the high-grade variant, which grows rapidly. Since it is a malignancy, it will also bring facial nerve paralysis, ulceration. Then you have trismus, draining from the ear, you have dysphagia. It has metastasis to regional lymph nodes, lungs, bone, brain, and subcutaneous tissues. You can see in this photograph the blue pigmented mass on the posterior lateral side of the heart palate. And in the lower photo, you can see the mucopyramid carcinoma on the tongue. It is also linked to some genetics also. Infrequent genetic loss at chromosomes 9q21, 8q, 5p, 16q, and 12p. HRAS genes have been shown to have mutation at codon 12 or 13. This is the genetic part. The tissue which after biopsy, what we receive, you can see in the photograph First is the low-grade micropyramid carcinoma, which may have a distinctly cystic cross appearance. You can see the cystic spaces filled with viscoid and mucoid material, and few areas of hemorrhage are also seen. The cut surface shows gray-white solid mass, which is accompanied by multiple small cystic structures and infiltrative borders. Now coming to the histopathological features, it is usually characterized by variety of cell types and growth patterns. Now, four types of cells are usually commonly seen, or the tumor is composed of four types of cells. First is mucosecreting cells, then we have intermediate cells, epidermoid cells, and then we have the clear cells or the columnar cells. Epidermoid carcinoma, it is of three grades are using: low grade, intermediate grade, and high grade. The mucoses, they vary in shape, have pale foamy cytoplasm, which stains positive for mucin stains, as it is filled with mucins. Relatively large, may assume round, cuboidal, ovoid, and columnar or goblet shapes, stains positive for mucicarbon and fast stain. Epidermoid cells, they are squamous and have polygonal shape. Intermediate cells, they are larger than basal cells, smaller than squamous cells, and the progenitor of epidermoid and squamous cells. They are considered to be progenitor cells. Then clear cells, they are large, polygonal, with a defined cytoplasmic borders. The histopathology grades are usually given on the basis of the amount of cyst formation, the degree of cytoplasmic atypia, and the relative number of mucous, epidermoid, and intermediate cells. Low grade. Now coming to the low grade variant, the hallmark feature is the prominent cystic structures, which is accompanied by the presence of numerous mature cellular elements, including mucous cells and extracellular matrix. In this variant, the mucous cells they are usually predominant. Squamous cells lining the cyst spaces are also seen. The size, shape, and staining characteristics of all the cells are uniform. Intermediate grade. Intermediate cells they predominate with scattered mucous cells and zones of epidermoid cells forming large solid islands of tumor. Mitotic figures are rarely seen. You can see in this photograph, this is the low grade variant with a prominent cystic complex. So you can see the various cystic spaces. The intermediate variant with few mucous cells and common population of intermediate and epidermoid cells. High grade variant. It shows us proliferation of epidermoid and intermediate cells, mostly epidermoid cells. Degree of age, quite a noticeable amount of cellular ATP is seen. Nucleus to cytoplasmic tissues also altered, with prominent nuclei and mitotic figures are numerous. Two differentiation patterns are also seen in mucopyramid carcinoma. First is which resembles the variants are sclerosing mucopyramid carcinoma is extremely rare shows central sclerosis that occupies the typical tumor. They infiltrate of plasma cells, eosinophils, and other lymphocytes at its periphery. Then we have two mechanisms are involved. First is the tumor infarction, and second is the extravasation of the lesions, which is resulting in the reactive fibrosis. Then we have intraosseous mucopurulent carcinoma. This primary intraosseous mucopurulent carcinoma of the jaw bone, it is extremely rare malignant salivary gland tumor, comprising only 2 to 3% of all the mucopurulent carcinomas. It's more commonly seen in the posterior part of the mandible. Histologically, it is a low-grade cancer. Radiographically, it is seen as uniocular or multilocular lesion. Photograph which is attached, you can see the posterior part of the mandible is affected. The differential diagnosis is necrotizing silometaplasia, then we have pleomorphic adenomas, then we have inverted ductal papilloma, then we have cyst adenoma, then we have metastatic squamous cell carcinoma, then we have sebaceous carcinoma, clear cell tumors, and adenosquamous carcinoma. Treatment is and the prognosis part. Excision is the or typical conservative excision with the preservation of the patient nerve. If submandibular gland is affected, the removal of the gland is preferred. Any minor salivary gland is affected, surgical removal. Metastasis is seen in 12% of the cases. Prognosis is fairly good. Then we have next topic is actinic cell adenocarcinoma. It is a salivary gland tumor malignancy which shows serous acinar differentiation. Abrams and his co-workers have concluded that the tumor of this type have at least low-grade malignant potential. It is defined by a cytological differentiation towards serous acinar cells, whose characteristic features of cytoplasmic false positive Zamolan type secreting immune cells. It constitutes around 17% of all the primary salivary gland malignancies and 6% of all the salivary gland neoplasms. Histogenic theories was given by Warsol and later by Regici and Batsakis, which says that this tumor arises from the stem of the reserve epithelial cells, which are located at the tubuloacinar terminal of the salivary gland duct, or that is the intergalactic duct bridge. Clinical features: the tumor is mostly seen in middle-aged persons, approximately 44-45 years of age. Females are more affected than males. The ratio is 3:2. The site is parotid glands are affected more, approximately 80%. Intraorally, leaves and buccal mucosa, they are more involved. Regarding the clinical presentations, it is a slow growing, mobile or fixed mass of variable duration. Asymptomatic, usually pain and tenderness seen over a third of a patient. Facial muscle weakness can be seen. Bilateral synchronous tumors have also been reported. As you can see, the actinic cell adenocarcinoma seen as a small or nodular mass on the heart plate. The histopathologic feature is highly variable morphologic features, which is well circumscribed and encapsulated. May exhibit infiltrative growth patterns. The characteristic cell is the serous sinus cell with abundant granular basophilic cytoplasm with round and darkly stained eccentric nucleus. Mitotic figures are shown. Now the morphological growth patterns is seen in the solid, microcystic, papillary cystic, and follicular. The individual cells, they are seen as sinus cells, intercalated cell, vacuolated cell, clear cell, and non-specific glandular cell. Solid growth pattern is most easily recognizable, contains large number of very well differentiated sinus cells, and most closely resemble the normal carotid gland. It is composed of sheets of tumor cells that frequently have an organelle configuration. It is a group of tumor sinus cells which are separated and surrounded by a very thin fibrous septa that contain small, nearly invisible capillaries. The clear cells, they are often macrocystic pattern. It is extensive in 1/3 of all the cases. Numerous small cystic spaces are seen. Sinus cells still frequent, may be a dominant dominating type. Vacuolated intercalated cells are prominent, and mucinous material may fall in the cystic spaces. Then we have papillary cystic pattern, in which the cystic structures that contain the proliferation of epithelium, which is projecting into the ligament. Some epithelial projections have fibrovascular pores, whereas the others appear to be masses of epithelium without apparent supporting stone. Epithelial proliferations, they may vary in thickness. Intercalated and non-specific glandular cells, they predominate, and vacuolated cells are also seen. The apical portion of the lumen lining cells, they bulge into the lumen, which is producing a kind of hobnail-like configuration. Then we have follicular pattern, which is the less frequent type. It is of variable size, over to round cystic spaces, which is lined by tubercle to low columnar epithelial cells. Cystic space, they contain a proteinaceous material that may stimulate the appearance of a colloid. Intercystic areas, they are usually occupied by epithelial cells that are non-specific glandular cells with some vacuolated and acinar type of cells. In this photograph, you can very well see the acidic cell carcinoma with extensive semoma body formation. Acidic cell carcinoma showing focal clear cell change. In the upper photograph and lower photograph, you can see the typical acidic cell carcinoma, which in areas of high-grade carcinoma, small cell features. This phenomenon has been referred to as dedifferentiation. The differential diagnosis includes the normal salivary gland, hydatitis, microepidermal carcinoma, microcystic type, papillary cyst adenocarcinoma, and clear cell oncocytoma. The treatment and prognosis part. Surgical excision is the treatment of choice, with the preservation of facial nerve. Then we have lymph node dissection. Internal tumors, they are surgically excised, and prognosis is poor. The next topic is adenoid cystic carcinoma. Now, the adenoid cystic carcinoma, it is more common and best recognized salivary gland malignancies. It is slow growing but is aggressive neoplasm with a remarkable capacity of recurrence. The perineural invasion is considered to be the hallmark of advanced cystic carcinoma. Now, the advanced cystic carcinoma, it is a basilar tumor consisting of epithelial and myoepithelial cells in variable morphologic configurations, including tubular, cribriform, cystic, and solid patterns. Clinical features more common in the 5th to 7th decade of life, more in females than in males. 50 to 60% of the cases they occur in minor salivary glands and more commonly seen on palate than on tongue and buccal. Clinical presentation is a slow growing mass. Pain is a common finding and it's the important one. Patients they usually complain of constant low grade dull ache with gradually increasing intensity. Facial nerve paralysis may develop within the carotid tumors. Parietal tumors can be smooth surfaced or ulcerated. Tumors arising in the palate or maxillary sinus may show radiographic evidence of the bone distress. Adenoid cystic carcinoma, which is the painful mass of hard palate and maxillary alveolar ridge. Whole of the alveolar ridges you can see in this photograph. On excision, the adenoid cystic carcinoma of the carotid gland has well delineated carotids, as you can see. And in the lower photograph, you can see white or grayish white color is form and the invasive kind of tumor, and areas of hemorrhage can be also seen. Coming to histological features, the adenoid cystic carcinoma is composed of a mixture of myoepithelial cells and ductal cells that can have a varied element. Three major patterns are usually seen. First is the cribriform pattern, then you have tubular pattern, and then you have solid pattern. Usually, a combination of all these three is seen, and the tumor is classified on the predominant pattern. Cribriform pattern is the most classic and best sequenced appearance, which is characterized by islands of basilar epithelial cells that contain multiple cylindrical cyst-like spaces, which is resembling a Swiss cheese or a honeycomb. These spaces often contain a mildly basically mucoid material and a hyalinized eosinophilic product, or a combined mucoid hyalinized appearance. Sometimes the hyalinized material also surrounds these cribriform islets. The tubular pattern, as you can see, the tubular structure which is lined by a stratified choroidal epithelium or longitudinal section ductal structures are also visible. The lumina usually contains fast positive material, and cribriform pattern it may also exist with the tubular pattern. Both the patterns can be seen in a same tumor. The solid pattern is a solid group of choroidal cells with a little tendency towards the duct or the cyst formation, arranged in nests or sheets of varying size and shape. Areas of necrosis is seen. Cellular pleomorphism and mitosis is also observed. As you can see in this photograph, solid variant showing scattered duct-like structures within the tumor. Next, you can see the upper photograph showing the tumor cells are surrounded by hyalinized material. And the lower photograph, you can see the tumor cells invading now that is called as the perinatal invasion. Differential diagnosis is basal cell adenoma, PLG, polymorphous low-grade adenocarcinoma, basal or squamous carcinoma, and basal cell adenocarcinoma. Coming to the treatment and prognosis part, surgical excision is a treatment of choice. The adjunct radiation therapy, which may greatly improve the patient's survival in some cases, and prognosis is unfortunately poor. Now coming to next salivary gland malignancy, is called as polymorphous low-grade adenocarcinoma. It is also called as globular carcinoma. It is also called as terminal duct carcinoma. It is the recently recognized type of salivary malignancy. It was first described in the year 1983. The term was first used by Evans and Matsakis. This malignancy occurs exclusively in the minor salivary glands. It is characterized by bland, uniform nuclear feature, diverse characteristic architecture, infiltrative and perinatal condition. Clinical features is more common in older age group, that is 50 to 80 years of age, more common in females, 2:1 ratio seen. Like 50 to 60% occurs on the palate, 16% is seen on the buccal mucosa, 12% is seen on upper lip, and the parrot, if occurs, if at all major salivary gland is affected, is the parrot, which is more commonly affected. Clinical presentation most often appears as a painless mass that may have been seen as a present for a long time and with a slow growth. This will be associated with bleeding, discomfort, injectasia, and ulceration. The tumor can erode or infiltrate the underlying bone. As you can see this photograph, ulcerated mass of the posterior lateral side of the heart. Coming to the gross pathology. It is firm, circumscribed, but non-encapsulated. Yellow tan lobulated nodule average is 2.0. Bony invasion may be seen in large regions in the heart palate, may impinge upon the medullary bone and can cause bone resorption as well as the literally medullary invasion. Now coming to the histopathological features, this characterized by infiltrative growth with diverse morphology and uniform nuclear appearance. At lower power, the tumor sometimes appears to be well circumscribed. Peripheral cells are usually infiltrating, invading the adjacent tissue in a single file fashion. It shows the different growth patterns, therefore, hence the name polymorphous is given. Variety of growth patterns, solid, ductal, cystic, tubular, or cribriform patterns. The tumor stroma, it varies from lucid to hyaline, and some is separated by a fibrovascular stroma. In some tumors, a cribriform pattern can be produced that mimics adenocarcinoma. Mitotic figures are uncommon, perinatal invasion is common. It's photographs. The upper photographs usually shows a medium power view, a cribriform arrangement of uniform tumor cells with pale staining nuclei. And the lower photograph you can see pale staining cells which infiltrate in a single file box. Next slide is again photos. The upper photo shows the tubular structures which are predominantly lined by single layer of small body cells, and the lower photograph showing the multiple pseudocystic spaces with pale staining amphiphilic mucoid content resulting in a cribriform appearance. The differential diagnosis is pleomorphic adenoma and adenomyocystic carcinoma. Coming to the treatment part, the polymorphic low-grade adenocarcinoma is best treated by wide surgical excision, sometimes including or resecting the underlying bone. Metastasis to renal lymph nodes is relatively uncommon, occurring in just under 10% of the patients. Therefore, radical neck excision seems to be rather unwanted. And distant metastasis is also rare.